Welcome back to Respiratory Rounds. This is series 2 in the two-part sarcoidosis series. Today we'll talk about respiratory involvement in sarcoidosis with different presentations, what are the syndromes involved, how to establish diagnosis, and latest updates in management of sarcoidosis. First of all, respiratory sarcoidosis, it can present in two forms. It can either be an acute presentation or it can present with a progressive infiltrative lung disease. In acute presentation, we have two syndromes, Lofgren's and Hereford syndrome, and in the progressive parenchymal lung disease, we can have hilar or mediastinal lymphadenopathy or interstitial lung involvement. Lofgren syndrome, which is one of the acute presentations of sarcoidosis, it's usually a self-limiting illness. It presents with fever, bilateral hilar lymphadenopathy on imaging, erythema nodosum, which is purplish patches on the legs, which are quite painful because of the inflammation of the fat under the skin. This generally has good prognosis and leads to complete resolution within 1 to 2 years. And a very minor group of patients, a minority of patients, can develop lung disease associated with Lofgren's. The second acute presentation is Hereford syndrome, also known as uveo-parotid syndrome. In this, the patients have fever, parotid enlargement, anterior uveitis, and facial lung palsy. Moving on to more chronic and insidious presentation of sarcoidosis, which is a progressive infiltrative lung disease. Most commonly, it presents with hilar lymphadenopathy, and this can usually be asymptomatic. Patients can present with cough of unknown origin with nothing in the parenchyma or chest pain. On CT scanning or on radiological investigations, the hilar lymphadenopathy is bilateral and is symmetrical. If it is unilateral and asymmetrical, it is less likely to be sarcoidosis. Systemic signs can be present, but they are usually infrequent, but they can present with arthralgias and myalgias. But full-blown arthritis is not part of sarcoidosis. Again, top differentials of hilar lymphadenopathy, tuberculosis, malignancies, lymphoma, periglossis, fungal infections like coccidioidomycosis, histoplasmosis, and also mycoplasma. There is scatting radiological classification of thoracic sarcoidosis, which is seen in the progressive infiltrative lung disease. Stage 0 is normal. We neither have lymph nodes, nothing in the parenchyma. And stage 1 is only hilar lymphadenopathy. Stage 2 is hilar lymphadenopathy with parenchymal infiltrates. Stage 3 is parenchymal infiltrates. And stage 4 is full-blown fibrosis. Second presentation after the hilar adenopathy is interstitial lung involvement. These patients are more symptomatic and they present with dyspnea, chest pain, malaise, and fatigue. They can also present with crackles and clubbing of fingers. Chest x ray will show some infiltrates bilaterally. Lung function can be normal or restrictive with reduced gas transfer. CT scan imaging. Some of the findings are very classic and associated with sarcoidosis. First of all, is the pattern of distribution. Distribution is usually in the upper and mid zones. And there are bronchocentric micronodules of 1 to 3 millimeter in size, and they present like bronchovascular beading. This is a very classical presentation of sarcoidosis. There can be clustering of small nodules around a central nodule, which is known as galaxy sign. It can be seen, but it is not pathognomic of sarcoidosis. Moving on to investigations. In addition to basic blood investigations like full blood count, serum ACE levels, chest x ray, lung function test, sarcoidosis is established with the gold standard of invasive tissue diagnosis. The diagnostic yield of various investigations is very variable. Endobronchial biopsies can give us a yield of 40 to 60%. Transbronchial biopsies up to 40 to 90%, and EBUS TBNA 54 to 93%, especially if there are lymph nodes involved. And if it is only parenchymal lesions, then transbronchial biopsies are preferred. Non-caseating granulomas on these biopsies is diagnostic of sarcoidosis. The clinching diagnosis in BAL is when the CD4 CD8 ratio is more than 3.5 and there is a significant lymphocytosis. Management wise, sarcoidosis is oral corticosteroids remain the first line. Though this comes with the caveat that sarcoidosis has very high rate of remission, so the treatment should only be started if there is a risk of fatal outcome. If the patient has increasingly worsening of symptoms, there is worsening of chest X-ray infiltrates and worsening of lung function test, development of neurosarcoidosis or cardiac sarcoidosis. If there is any kind of possibility of permanent disability, especially with involvement of eyes, or if there is unacceptable quality of life. Typical regime is starting prednisolone at the dose of zero point 0.5 milligram per kg, usually initially for 4 weeks, and then a slow taper to maintain a daily maintenance dose where the symptoms are minimal. IV methyl prednisolone can be given in acute presentations of cardiac and neurosarcoidosis. As with any steroid medications, patients should be given adequate gastric protection. Bone monitoring should be done. Bisphosphonates should be prescribed if they are at risk of osteoporosis. There is need for blood pressure and blood glucose monitoring as well. In patients who are not responders to steroids and we are unable to wean down steroids, then we can use the second line agents, which can be used as steroid sparing agents. Hydroxychloroquine is commonly used when patients have excessive fatigue and especially in joint and skin disease. Methotrexate is also used and is given once weekly, 10 to 15 milligram, initially for a 6-month trial, and it can be used either in addition to prednisolone or as a standalone agent. But we have to be careful regarding liver and renal involvement, and monitoring of full blood count is advised. Azathioprine is used in patients with neurosarcoidosis or stage 2 and 3 pulmonary sarcoidosis who have partial or no response to steroids. The usual dose is 100 to 150 milligram per day. Other agents which are recommended are mycophenolate and leflunomide. Regarding inhaled steroids, there is no evidence for routine use. They can help with cough and airflow obstruction, but the inhaled steroid should not be used as first line for management of sarcoidosis symptoms. If patient has concurrent asthma, it should be managed separately. A patient who has been on steroids and has also taken the second line medications but is still symptomatic and we are unable to wean down prednisolone down less than 10 to 15 milligram per day, or there is a progressive pulmonary disease or intolerance to steroids, we should escalate therapy. And before escalating the therapy, always reconfirm the diagnosis and check treatment adherence. After second line, the therapy can be escalated to biologics and antifibrotic agents. In biologics, infliximab has been shown to improve disease control. It was approved by NICE in 2023 for refractory sarcoidosis, excluding neurosarcoidosis. As with any biologics, we should screen and treat latent TB before starting. The dosing is every 2 weeks initially, and then it can be given 4 to 8 weekly as well. Amongst the antifibrotics, nintedanib has been used for sarcoidosis related progressive fibrosis. Its main side effects are diarrhea, hepatotoxicity. Bleeding risk has been found to be low in sarcoidosis patients. With regard to long term prognosis, there is no particular prognostic marker that can be used. Among the prognosis is decided based on the presentation. Like Lofgren's has good prognosis, and symptoms which are associated in patients with HLA DQB1 are generally have been shown to have good prognosis. Poor prognosis in chronic presentations like lupus pernio, chronic uveitis, neural involvement, if the presentation is after 40 years of age, nephrocalcinosis, and hypercalcemia. Chest X ray has been used to prognosticate, in which stage 2, 50% recover spontaneously in 2 years. Stage 3, they can have worse prognosis, and only 30% they show significant improvement with steroids. Thank you for watching. Thank you for your time. Follow Respiratory Rounds for more educational content, and comment below how did you find this series and what is your experience in managing patients with sarcoidosis. Thank you.